The content of this podcast is provided for general informational purposes only and is not intended as, nor should it be considered a substitute for professional medical advice. Hello, this is Karen Nickel, family nurse practitioner, and you are listening to Itchy and Bitchy, a podcast that provides answers to your many unanswered health questions. I have some very exciting news to share with my wonderful listeners. For almost 9 years, I have been the host of Itchy and Bitchy, formerly named Sweaty and Pissed. It is time for the podcast to grow and evolve with new hosts and a slightly different format. Growth and change is a good thing, people. My dear friends Stephen Miller and Keith Nilika will be the future hosts of Itchy and Bitchy. As hosts, they will have a comprehensive approach to wellness with a focus on connecting human health, animal health, and environmental health. To provide a transition period for you, for me, and for Stephen and Keith, we have a series of 4 episodes planned. I will introduce Stephen Miller, a fellow nurse practitioner, in the first of 4 episodes. In the next episode, I will introduce you to Keith Nilika, a veterinarian. The 3rd episode will include all 3 of us as I interview both Stephen and Keith. All 3 of us will also be in the 4th episode, but this time the tables will be turned and Keith and Stephen will be interviewing me. I'm confident you will enjoy and learn from all that they have to share. Stephen Miller is an acute care nurse practitioner known for his expertise in diagnosing and treating cardiovascular disease. He is highly respected for his patient-centered approach, consistently ensuring that each individual remains at the heart, no pun intended, of their care. Committed to excellence, Stephen earned his Doctor of Nursing Practice from Vanderbilt University, further strengthening his clinical knowledge and leadership in advanced nursing practice. Most importantly, from my point of view anyway, we have been friends for about 25 years. Welcome, Stephen.
Hi, Care.
Stephen and I are going to chat about something called Takotsubo cardiomyopathy because I suspect that many of you have not heard about this heart problem. So, Stephen, let's first define cardiomyopathy. Let's start there.
Yeah, so cardiomyopathy is anything that decreases the function of the myocardial tissue and can lead to weakening of the left ventricle and or later, more severely, congestive heart failure types of symptoms. So,
yeah, not good. So what about Takotsubo cardiomyopathy? What makes that different? What is it?
Yeah, so Takotsubo is an interesting syndrome. It is otherwise also known as broken heart syndrome. It is this temporary condition that is triggered by intense emotional or physical stress. It mimics something that we call acute coronary syndrome, which can come with obstructive coronary artery disease. However, the difference for Takotsubo is that there is no obstructive coronary artery disease or blockage in the arteries as the cause for this particular event.
It's so interesting. So what are the likely symptoms of this problem?
Most women will experience an intense emotional or intense psychological stressor that triggers the events, and it presents.
And a lot of women have those, by the way.
Yes, they do. And they present with what would be like a typical heart attack.
Oh.
So coming in with chest pain or unusual shortness of breath. Of course, you always have to remember in women, symptoms are also atypical. So a lot of those symptoms can present as jaw pain or back pain. So some atypical and typical symptoms. Generally, examples of triggers for women for these events would be some intense event like the death of a family member or a loved one, an acute illness, a surgery, a stroke, and sometimes other severe psychological stressors. So,
yeah, I had a patient with Takotsubo, and she was in a very difficult relationship. She was really struggling on how to make this this relationship work, and the stress was so immense that she ended up with Takotsubo cardiomyopathy. It's incredible.
Yeah. I've seen a number of cases over the 26 years of practice in cardiology, and all with different presentation situations. I have one patient who experienced her husband injured himself, and she had an episode right there in her yard during his event. And so, it's real, and the symptoms are real, and the end organ effects of it are very real. It's interesting, has a funny little name. Takotsubo is something that is named after the octopus trap. So
something that catches octopus.
Yes. That's right.
Okay.
So when we look at echocardiograms and heart catheterizations for women who have Takotsubo, or men, more rarely men, you see this classic sort of ballooning of the apex or bottom part of the heart. And so you get this sort of narrow neck at the top and ballooning of the ventricle. And that's where it essentially gets its name from. And it's very typical and very classic presentation. And once you see it on echo or cardiac catheterization, you know exactly what
it's pretty clear
Yes.
on that imaging that that's what's going on.
Yeah.
Oh, good. Are there certain people who tend to get this or have greater risk of developing Takotsubo?
Yeah, 90% of the cases are women or female people, particularly among postmenopausal women, as there is a strong trigger from the hormonal shift that happens at menopause and declines in estrogen levels. Around the age of 55, risk goes up, and honestly, the majority of the cases that I've seen over the years have been women in that age group.
Yeah.
There are also other sort of pre-existing conditions that can set someone up for having Takotsubo, so like neurologic conditions, stroke, epilepsy, and then, of course, anxiety and depression. And who doesn't have anxiety and depression?
Yeah.
So lots of people.
It's really quite incredible and interesting that we now know that estrogen is so heart protective, and the lack of estrogen is part of the reason women experience this way, way, way more than men.
Sure. And when you take that into account for the fact that during these events, you get this intense surge of fight or flight response. And so all of that ramps up and causes this intense vasoconstriction in the coronary arteries and subsequent lack of blood supply to the myocardium or heart muscle. So catecholamines are not our friend in this situation.
Gotcha. We're going to take a quick break. And after this break, we will talk about who is the likeliest person to come up with Takotsubo cardiomyopathy. We'll be right back. Welcome back. So you mentioned a couple of other things that put people at risk, but are there other events that could trigger Takotsubo?
Oh, yeah. So you look at sometimes surgical events. People can have intense catecholamine release during surgery. Of course, death of a loved one, relationship breakups, which large percentage of people go through divorce in the middle age of life. I've seen a number of cases in our office of people who were having intense arguments with a loved one, a husband or a family member. And then, of course, intense fear can set off these events of this surge of catecholamines or catecholamine-mediated events that people get. So,
So like if you were hiking and a bear started running down the trail right at you and you managed to survive it.
The bear, yeah.
Yeah, if you survive the bear, the fear from that experience could trigger this.
Yeah, or if your husband were a bear.
Yeah. Well, if you're marrying a bear, that's a little weird. But hey.
But hey,
to each his own.
It happens.
So you mentioned the echocardiogram or angiogram, that there's clear physical findings to help confirm your suspicion of Takotsubo. Are there any blood tests that you do for that?
Yeah. So when someone presents, say, for example, they come in the emergency room and they have the presentation of, angina, acute coronary syndrome type of thing, we run an EKG. So a basic EKG can show some ST segment elevation or depression, depending on where they are. Additionally, you would get now high sensitivity troponins or troponin levels, which often are elevated and not always peaked like they might be with an acute occlusion of an artery, because you have to remember this is a transient occlusion. Back to EKG, again, we see ST segment elevation, ST segment depression, T wave inversion, and even QT prolongation. So all of that, putting that in English, just EKG changes that might show up.
That are typical for this problem.
Pretty typical, yeah. And then once level of suspicion is high and screening testing is indicative, then you would move on to something like a heart catheterization and or echocardiogram. Generally, in this situation, we would end up doing both. The cardiac catheterization is particularly helpful because it helps us to diagnose coronary disease or flow-limiting disease.
So you're ruling out that part.
That's right.
Ideally.
And in Takotsubo, you would not see necessarily flow-limiting coronary disease. And then we also do what's called a LV or left ventriculogram, shoot dye into the left ventricle. And that's where we would see that ballooning of the apex of the left ventricle.
Yeah. Interesting. So say someone gets diagnosed with Takotsubo cardiomyopathy. Is there hope? What is the treatment for the condition?
When the blood flow to the heart is temporarily blocked and a patient has an event, and then you see some weakening of the left ventricle, and you don't see any flow-limiting disease, and you've determined it's a Takotsubo, the prognosis is really quite excellent because with medical therapy, then you can see significant improvements. So prognosis is excellent. Bad outcomes are pretty rare. It's about mortality rate of about 1% to 3.2%. And that includes, things like life-threatening arrhythmias and that kind of thing.
And that might happen because the heart's baggy?
It's boggy. And it's not pumping efficiently.
Right.
And so when we help people through the acute phase of Takotsubo with medications, and we give medicines to help decrease the work of the left ventricle and medications that help improve ventricular remodeling, then we start to see the heart go back to its normal shape.
And so what kind of medications are those? What typically would you start?
So it's interesting. There are treatments considered to be supportive because certainly in this situation you would not do any kind of intervention. You wouldn't need to do intervention as far as stents or angioplasty or anything like that. But treatment is tailored to what we call hemodynamic phenotype, or in English, basically the person's hemodynamic presentation and what their body can tolerate as far as adding on GDMT or guideline or directed therapy. There are no guidelines currently because there aren't any randomized controlled trials looking at standards of care for these patients.
Oh, maybe because it's mostly women?
One can only ponder.
But listen, my listeners hear me say this all the time now. You know that didn't get studied because it's a women problem.
So yes, the truth of what you're saying is that historically when women are underrepresented in population studies. And so the data historically has been skewed to the male population, and that's very accurate.
But you would use medications you would use often in heart failure of other causes, so that like beta blockers and
so things like
like
beta blockers like metoprolol, which we would use in acute coronary syndrome, ACE inhibitors, ARBs. Those things are helpful. Definitely some type of aspirin and or Plavix, because clearly if that person had a tendency toward having a Takotsubo event, you would want to make sure they're protected moving forward. They don't need another insult. The interesting thing about that is that reoccurrence rates are actually pretty low, but they do happen. They're at about 1.5%.
Yeah. So if somebody has this, they can feel it's terrible that it happens, but they can feel pretty good about regaining heart function.
Yes.
To normalish levels?
To normal,
50%,
yeah. Yeah, so we repeat an echocardiogram when they come back, and as a general rule, their ejection fractions improve and myocardial function returns to normal. And that usually happens somewhere between 3 to 6 weeks.
Oh, okay. The ejection fraction tells us how well the left ventricle, the bottom left chamber, is squeezing.
Yeah.
So we're looking to see if they've regained the function that we want to see in that left bottom chamber.
That's absolutely correct. Yeah. So the ejection fraction is the percent of blood pumped from the left ventricle with each contraction, and it's normally somewhere between 50 to 70%, somewhere in that range. A lot of these people will see their ejection fractions during their event decline into the 30s, 20s, but then with proper medication, then you can see those the ventricular recovery occur.
So it's hopeful for the people who experience this that they'll recover function pretty quickly, and the chances of it happening are pretty slim. Do you ever, as a cardiology practitioner, do you send them for cognitive behavioral therapy or anything that would help avoid another event? If an emotional stressor especially was one of the triggers for the event?
Yes. So a lot of people who have intense emotional reaction around events in life may benefit from certain medications for their anxiety, or if they're bipolar or whatever underlying psychiatric issue is going on. And so it's a very good idea to get these people connected. I've actually historically given a couple of the patients, treated them with SSRIs, and there is a slim amount of evidence there. Serotonin reuptake inhibitors. So yes, behavioral
and those are
cognitive
things
therapy.
like Prozac, Paxil, Lexapro.
Yeah.
Just for our listeners. Yeah,
that's right. And so yes, a good referral to mental health specialty is vital. Cardiac rehab is another really vital part of recovery. A lot of people, when they have this event, feel utterly exhausted. So the heart deconditions really rapidly when you have an event. And people will notice unusual fatigue for weeks after, shortness of breath for weeks after, while the ventricle is recovering, and their bodies are having to get readjusted because there are now new medications on board with all kinds of side effects that they have to deal with. But certainly cardiac rehab is highly recommended for these folks.
Yeah, that's great. I just think this is a really interesting subject and one that I don't think gets talked about a lot. And so I appreciate you filling in all that information that most of us don't know. I really appreciate that. Is there anything you would like to share about who you are or what you hope to bring to the listening audience as a future host?
Yeah, I think this will be super fun and exciting. I'm definitely, after 26 years of practice, I've got lots of experience with all manner of people and on multiple levels. And I think the ability to bring that rich history of practice into conversation with people and present data in an appropriate way. That's another thing especially through my doctorate work. So we have studied that and spent a lot of money on degrees learning how to gather up that data and present it in a way that people can understand. And so I think the ability to do that we should be able to enhance people.
Yeah. Well, I think the listeners over the last almost 9 years, I do talk about studies in most of my episodes. I don't go into p-values and all that. But I think it's helpful for people to know what's being studied, what the results were, how many people were in the study,
That's right.
that kind of thing.
Helping people tease through that's really important.
Yeah, I think so too.
And historically, with women, the population of women in studies within medicine have been underrepresented.
Mm-hmm.
And so maybe we have missed the mark on finding pathways for women in healthcare.
Yeah.
So,
I mean, the fact that 90% of the patients who experience this are women, and we don't have information really on the best way to treat that. And we're in 2026 is sort of incredible.
There are no guidelines.
Yeah, Well, I won't go on my tirade. I promise. All my listeners are going, oh, thank God. Well, I'm so glad you're here. I'm so glad Keith is going to be here with us. And I also want to point out that you're a musician and Keith is an artist. And so they, have similar experiences that I have as a musician. So they bring that to the table as well, which I think is a really good fit for this podcast.
Sometimes it takes an artistic mind to take something so technical and look at different ways of getting across to people.
Yeah.
And certainly music being so scientific, but yet so creative and colorful, and it taps into our right brain. And so it allows us the ability to extend beyond the sort of robotic care that I think people really just don't want.
Yeah, we love our right brain. Love it.
Love it. I am working to preserve mine every day.
I know, it's important.
Piano lessons, singing, all of that.
See? Yeah. That's so good.
Yeah.
Keith, painting.
Painting.
My gosh, it's so important. Right brain is so good.
It is.
Well, thank you so very much, Stephen. I'm excited that you're coming on board, and I appreciate your time and knowledge about Takotsubo.
Well, thank you, Karen. We love you very much and consider you family. And we're so excited to do these next few episodes with you. And,
it'll be fun.
And continue to honor your work through this podcast to your listeners. I think that's a brainchild of yours, and we're just thrilled to be able to carry it forward.
I appreciate that very, very much. I appreciate that. Well, many thanks to all of you out there for listening. And wherever you listen to this podcast, please leave a review and rate the podcast. Your reviews and ratings really do matter. Also, make sure you follow the show so that it will be automatically downloaded. That absolutely matters. I encourage you to visit our Facebook page, IMB Podcast, where you can give us a like or leave comments or questions for me. Our website is itchyandbitchy.com, where there are blogs with some of our subjects available for you to read. Thank you to Forrest Wenzel, my son, our producer and composer of our theme music, and the person who does all the behind-the-scenes work to make this podcast possible. Thank you so much, Forrest. And Forrest continues to thrive at Peabody Music Conservatory and is finishing up his final semester of the master's program. And he has informed us that he has been admitted to the Peabody doctoral program to receive a Doctor of Musical Arts in Composition. His dad and I are so very happy for him. It's fun to see his immense musical talents recognized. If you want to listen to what he's creating, you can go to his website, forrestwenzel.com. Remember that your health is in your hands.